bleeding. Definition abnormal के पहले अगर कोई चीज जाननी है तो you should know what is normal uterine bleeding. So normal uterine bleeding is defined as the menses which is occurring at every 28-day cycle plus minus 7 days with the mean duration of 5 days, means 3 to 9 days, and average blood loss is about 30 to 80 ml. That is a normal blood loss, means a cycle which is having a definite cyclicity, frequency, duration, and amount. Having a sub everything is within this limit, then this would be known as the normal uterine bleeding. You know, the cause of the normal cause of the bleeding is shedding of the myometrium under the effect of estrogen and progesterone. This is the effect of estrogen and progesterone, and when there is a shedding, then this will cause the menstrual cycle. So abnormal bleeding is that bleeding which is abnormal in regularity, that is in cyclicity, volume, frequency, or duration. Means 4 things: regularity, volume, frequency, and duration. And most important thing, there should be no evidence of the pregnancy, infection, or the malignancy. Initially, we are using the term dysfunctional uterine bleeding, but this term is outdated. It is not used nowadays. So as the FIGO in 2018 has classified what is normal and what is abnormal. So normal means, you can see what is the normal menstrual cycle when it is having a frequency of 24 to 38, frequency of 24 to 38 days, regularity of the cycle is present, and duration of flow is 4.5 to 8 days, and the volume of the blood loss is 20 to 80 ml. This is known as the normal blood loss. Now, this blood loss to assess is a very much subjective variation. So for this, we are having a scoring that is known as a pictorial blood assessment chart, depending upon the how much pad the patient is, or the woman or the girl is using, and how much it is soaked with the blood. Slight, as you can see in this, moderate, or the heavy. Depending upon this, they have been given a scoring, and if the scoring is more than 120 points, then it is said to be a heavy menstrual bleeding. It is clear, bachcho? Pictorial blood means heavy blood loss, means it is more than 120. Now, what is the etiology of the abnormal uterine bleeding? Etiology is starting before the menarche even, when there is a presence of some foreign body, ovarian tumor, or might be in the newborn due to the estrogen withdrawal bleeding from the mother. And then at the time of menarche, it is usually because of the coagulation defect. Out of this, platelet disorders and the von Willebrand disease is the most common cause, and naturally is the psychological causes, also very common at the age of adolescence. In reproductive, the pregnancy disorders, ovulatory and the anovulatory disorder, and sometimes due to the anatomical cause. The postmenopausal patient, always you have to rule out the malignancy, might be CS cervix, uterus, vagina, fallopian tube, and sometimes due to the endometritis senile or the senile vaginitis, or due to the hormonal replacement therapy, that is estrogenic. So our role as a gynecologist to differentiate what is the cause of the bleeding, if the patient comes in the prepubertal age, adolescent age, in the young reproductive age, or in the postmenopausal age. Initially in the FIGO 2007, it has given a classification under 2 categories. Previously, we were using the term dysfunctional bleeding, but it has been replaced by the AUB. So this is the 4 causes comes under the this structural abnormalities, and the 5 causes under the non-structural abnormalities, and this is known as the PALM, 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 and the COIN, COEIN. COIN is having a E also. So this is having a COIN classification. In the palm, you are having a polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. While in the coin, you are having a coagulation disorders, ovulatory dysfunction, endometrial disorders, iatrogenic, not yet classified. After that, this was the old classification we are using, that whether the patient is having oligomenorrhea, polymenorrhea, menorrhagia, metrorrhagia, menometrorrhagia, dysfunctional uterine bleeding. But these old terms, they are not used nowadays. Still, you should be aware, because sometimes in the OPD to write down, it is very easy. So this has been replaced by the that I have told you, the palm coin classification. Before that, in 2011, the FIGO has added 3 words. The abnormal uterine bleeding, it is categorized under 3 categories: acute, intermittent, and the chronic, depending upon the regularity in the frequency, cyclicity, duration, and the amount. And after that, again, it was classified under the palm coin classification, that is polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not yet classified. So before that, it has been classified under 2 categories, whether it is acute or it is chronic. The acute has been classified when it is having a so much heavy bleeding that there is a need for the admission immediately, or some intervention, means too much heavy bleeding. But chronic DUB, which is having abnormal either in duration, volume, frequency, or regularity, and it is persisting for last 6 months. So depending upon this cause, you have to define it is the acute or the chronic. This classification was given by the FIGO in 2011. After that, FIGO 2018 has added the 2 new terminology also, that is the intermenstrual bleeding and the heavy menstrual bleeding. Intermenstrual bleeding, that is a bleeding which initially we are saying as a metrorrhagia, randomly occur at any time. And heavy menstrual bleeding means that amount of the excessive blood loss which interferes with the woman physical, social, emotional, or the material quality of the life. Because they have classified under these 2 categories, because they are the 2 main symptoms on which basis we have to hospitalize the patient, or we have to start the treatment. So you see, this is the FIGO 2018 classification, in which it is classified as the palm coin category, abnormal uterine bleeding, under 2 headings: heavy or the intermenstrual bleeding. Heavy means HMB, intermenstrual bleeding is known as the IMB. There is no acute, chronic, or intermittent group of the classification. And again, it is subdivided into the palm coin classification, depending upon the patient is having a structural abnormality or the non-structural abnormality. The causes of the AUB in the non-pregnant reproductive aged women. This is very important, because there should be exclusion of any pregnancy disorders like incomplete abortion, missed abortion, ectopic pregnancy, inevitable abortion. All this you have to exclude. Only then you can keep the patient in this FIGO classification 2018. It is clear, beta? Can you hear me, बच्चों?
Yes, ma'am.
Yes,
Yes,
sir.
ma'am.
Yes,
तो
ma'am.
किस क्लासिफिकेशन में हुआ पाम 2018? Heavy and
Intermenstrual. Intermenstrual.
Intermenstrual.
again into the palm and coin group. Okay.
Yes,
So
ma'am.
now I am taking every group separately. One is the AUB P. P means, when you write AUBP, means abnormal uterine bleeding and the polyp. That is present in 8 to 35% of the patient. In the postmenopausal patient, it is present in 21 to 28%, and it is a very common cause of the postmenopausal patient, while the incidence of the malignancy varies up to 4.8%. And here, you know, the diagnosis is usually by the ultrasound, TVS is the most important ultrasound investigation, saline infusion sonography, and sometimes hysteroscopy if it is indicated. So first you have to confirm what type of the polyp it is. Like this, here you can see what is this. ये क्या दिख रहा है बच्चों? ये पूरा क्या दिख रहा है? ये क्या दिख रहा है? यूट्रस. और ये क्या उसके अंदर? कैविटी. और ये क्या चीज है? कुछ बोलोगे नहीं बच्चों?
Polyp.
So this is the polyp, and here you can see this is having so much fluid inside it. So it is diagnosed with the help of saline infusion sonography. So after the diagnosis of the polyp, you have to remove it by the polypectomy. And this is done by which method? ये क्या दिख रहा है?
Hysteroscopic.
हाँ, हिस्ट्रोस्कोपी में पॉलिप आपको दिख रहा है. ठीक है, तो आपने हिस्ट्रोस्कोपी से इस पॉलिप को निकाल दिया. सेकंड इज द एडिनोमायोसिस, दैट इज नोन एज द AUBA. The incidence varies from 5 to 70% depending upon the what criteria have to use the sonographically and depending upon the expertise of the sonologist. The sonography appearance of the adenomyosis is there is a presence of the heterogeneous myometrium due to the presence of heterotropic endometrial tissue in the myometrium and partly due to the presence of the myometrial hypertrophy. And second most important point is the loss of the endometrial myometrial surface. Sometimes when you are not able to diagnose by the TVS transvaginal sonography, then you have to take the help of the MRI depending upon the case. So here you can see the ultrasound finding of the adenomyosis, that the uterus has been enlarged. This is the anterior surface of the uterus. This is a posterior surface, because anterior means here is the bladder and this is a posterior, and you can see there is a myohyperplasia, and here you can see some heterogeneous myometrium and loss of the endometrial myometrial surface. जैसे आपको नॉर्मली एक कैविटी अच्छे से दिखती है, वो यहाँ पर नहीं दिख रही है. तो लॉस ऑफ एंडोमेट्रियल मायोमेट्रियल सरफेस, heterogeneous myometrium, enlargement of the uterus, usually of the posterior wall of the uterus, is diagnostic of the adenomyosis. Now third is the AUBL. What do you mean AUBL means? Abnormal uterine bleeding due to the leiomyoma. In this case, you can see there are the different type of the fibroid, submucous fibroid, intramural fibroid, or a subserous fibroid, intramural fibroid, or the submucous fibroid. They are the cause for the abnormal uterine bleeding. They are classified by the FIGO under the 7 categories. S means beta submucosal. Submucosal. That comes under 0, 1 and 2. 0 means completely inside. 1 means usually more than 50% inside, and here is less than 50% inside. So this importance of diagnosis is by the 0 and 1 you can remove by the hysteroscopy. Then 2, 3, 4, 5 and 6. These are the intramural fibroid, as you have seen the classification, and these has to be removed depending upon the position by the expert endoscopist, combining with the usually with the laparoscopy. But the 7 one can be very easily removed by the laparoscopy, the 0, 1 by the hysteroscopy, 7 by the laparoscopy, and all this depending upon the expertise, position, size of the leiomyoma. Then comes the hybrid leiomyoma, when do you find 2 numbers 2 to 5 submucosal and subserosal, each with less than half the diameter in the endometrial and the peritoneal cavity respectively. So we are classifying as the abnormal uterine bleeding L under the 7 categories, as you can see in this. And when you classify, you write the AUBL, then depending upon which category you have to write down 3, 4, 5. There are the 3 leiomyoma, you can write down 3, 4, 5, like this you can write down. so that it will tell you the situation. Initially, we classified only the three categories: submucous, intramural, subserous, depending upon the diagnosis by the MRI and the ultrasound. But nowadays, I have shown you the classification. On this basis, you are writing down whether it is L1, L5, 6, whatever the position and the size of the myoma. Now comes the malignancy and hyperplasia that comes under the category of AUBM. M means malignancy. You can see that this has been diagnosed in a postmenopausal patient if she comes with the postmenopausal bleeding, and the confirmation was done by the endometrial biopsy. About 40% of the patient, when you find some complex hyperplasia with atypical hyperplasia, it may show the presence of endometrial carcinoma. Then comes, I finished the structural abnormalities, that is the palm, polyp, adenomyosis, leiomyoma, and malignancy. Now coming to the non-structural abnormalities, that comes under the Cohen classification. Cohen classification means the coagulopathy, O means ovulatory dysfunction, E means endometrial, I means iatrogenic, and N means not otherwise classified. Under this coagulopathy, you can find all the bleeding disorders, and the most common bleeding disorder in the adolescent age group is the von Willebrand disease, might be placental dysfunction, platelet disorders, and some factors deficiency like factor 10 and the factor 11 deficiency. Now there is a change by the FIGO in 2018 that if the bleeding is occurring due to the anticoagulants, then it won't come under the coagulopathy, but it will come under the category of AUBI, means under the iatrogenic category. So this is the new modification has been done by the FIGO in 2018, but otherwise any bleeding which occurs due to the coagulating deficiency factor, due to the platelet disorder, or due to the von Willebrand factor deficiency or disease, it comes under the category of AUBC. Now, coagulopathy, how will you diagnose any patient who comes with the heavy bleeding from the time of menarche, having a heavy bleeding at the time of delivery, having a surgery-related bleeding unexplained, having a more than normal bleeding at the time of removal of the some dental work, having a family history of bleeding disorder, frequent history of at least every month of epistaxis, some bruising disorders, or some ecchymosis or patches on the surface, that is diagnostic of the coagulopathy. And always all these girls or the women, they should be screened for the bleeding disorders. Now comes the AUBO, means ovulatory dysfunction. Ovulatory dysfunction means anything that is unpredictable amount of the bleeding, which is not due to the other organic causes. I told you the adenomyosis, fibroid, or the malignancy or the pregnancy disorders. The patient may present with the amenorrhea, then there is a history of the light and infrequent bleeding that is unpredictable. Sometimes these patients may need some medical and surgical intervention, and they may present with the heavy bleeding. The causes of this AUB are ovulatory dysfunction, bleeding disorders are polycystic ovarian disease, hypothyroidism, hyperprolactinemia, mental distress, anorexia, obesity, weight loss, extreme exercise at the time of adolescent transition, and the menopause. So patient has to be investigated under the following headings. Then comes the endometrium. Endometrium means which is typical of the ovulatory cycles and when no other cause has been identified. The mechanism is probably a disorder of the endometrium. So it is a diagnosis of exclusion. The most common mechanism, you can see that all the factors which are regulating the hemostasis, they might be disturbed. Like there is a deficiency of the local production of the vasoconstrictors, endothelial 1 and the prostaglandin F2. Normally, there is a balance between the prostacyclin E2 and the prostacyclin I2. When this is disturbed, or there is an excessive production of plasminogen activators. At that same time, there is a defect in the endometrial repair and the means shedding and the generation. There is a disturbance. Shedding is more and the repair action is slow. So this may cause the abnormal uterine bleeding or might be associated with the subclinical chlamydial infection. So now lastly is the AUBI. I means iatrogenic. The iatrogenic means may be under the effect of some drugs, might be some intrauterine devices, or might be due to the some interference which you have been done. The normally or my like intrauterine devices, the drugs which are commonly used, which may cause iatrogenic bleeding if they have not taken properly, like OCP, continuous progesterone, then the cigarette smoking, rifampicin, and the tricyclic depressant and the anticoagulant drugs. I've told you this classification was initially under category of C, but the FIGO has been changed now from C to I recently in 2018. So iatrogenic is a very common cause because the patient when goes to the some private practitioner, they prescribe some OCP, but if the patient is not taken in the prescribed dose or in the prescribed format, if she is taking irregularly, then she may suffer from the iatrogenic type of the bleeding, that is known as the AUBI. Then comes the AUBN, not otherwise classified. This comes under this heading. Two things, they are very important. These are the AV malformation and the endometritis, or any other new type may come under this category. Disorder should be defined only by the biochemical or the molecular biology studies. Some disorder, some receptor deficiency, that these two are the most common under this category: chronic endometritis and the active venous malformation. Active venous malformation is diagnosed by the TVS and the color Doppler, and endometritis by the histopathology when you take the tissue. So after this classification, knowing the causes, I will tell you what is the approach. The guidelines is always you do the general assessment, find out the some hemoglobin, thyroid, some polycystic ovarian disease, obesity, along with the history, general assessment. Then you find out the second is you take the history also and the screening for the hemostasis disorder. Then whether it is an ovulatory disorder, then evaluation of the endometrium, evaluation of the endometrial cavity, and along with the evaluation of the endometrium, the myometrial assessment is very important. So that AUB has to be assessed under these 6 categories: general assessment, whether it is an ovulatory disorder or not, any hemostatic abnormality, endometrial disorders, endometrial cavity disorders, or the myometrial disorders. In the general assessment, as you see, any cause related to the pregnancy has to be excluded. Find out from where the bleeding is coming, whether it is coming from the vagina, vulva, perineum, perianal, from the cervical canal, means it is definitely coming from the uterus, not from any other side. Then you have to evaluate for the anemia. For this, find out the hemoglobin, PCV, platelet, and the serum ferritin and TIBC. Once the bleeding has been identified, has been confirmed that it is originating from the cervical canal or from the endometrial cavity, then it has to be classified under the different components, whether it is a structural or non-structural, that is a palm coin classification. So if the bleeding, then so you have to classify whether it is AUBO or not. That's usually, initially we are doing the endometrial biopsy very commonly and the serum progesterone estimation. But nowadays with the invent of so many important investigation, especially transvaginal ultrasound, this endometrial biopsy is not the first method of recommendation. So general assessment, after the general assessment, we take a proper history for to exclude the von Willebrand disease, to find out whether it is a bleeding disorder or not. If the heavy bleeding disorder is presenting since menarche, having one of the following, that is postpartum hemorrhage, surgically treated bleeding, bleeding associated with the dental work, or two or more of the following symptoms, that is bruising 1-2 times per month, epistaxis 1-2 times per month, frequent gum bleeding, family history of bleeding symptoms, then you should suspect that it is a von Willebrand disease. Now, determination of the coagulation disorders means after taking the proper history, how will you confirm? You do the BT-CT estimation, PT, activated partial thermoplastin time, von Willebrand factor, antigen and its activity, resistant cofactor activity, and factor 8. So, if these tests they are abnormal, then you will suspect the patient is having a von Willebrand disease, and patient should be referred to the hematologist for the consultation. Coagulopathy can be very easily diagnosed by the proper history. Then the evaluation of the endometrium. Evaluation of the endometrium is very much necessary if the age of the patient is more than 45 years, just to exclude the malignancy. But even on all the patients who are giving a history of malignancy, they are obese, even if they are less than 45, suspecting malignancy in cases of Lynch syndrome or polycystic ovarian disease, or if the bleeding is persistent, unexplained, inadequately treated, or there is a suspicion of the malignancy having a diabetes, hypertension, or there is a endometrial thickness is more than 12 millimeter. In this cases, always you have to do the hysteroscopic evaluation to find out and take the endometrial sampling to confirm by the histopathology what is there any evidence of the malignancy. Evaluation for the chlamydial infections. Evaluation of the structure of the endometrial cavity. Endometrial structure evaluation is very much necessary because I've told you in 25% cases the polyp is a very important cause even in the reproductive, in the postmenopausal bleeding. TVS is not a very 100% sensitive, but usually it can diagnose polyp. If there is a problem in diagnosing by the simple ultrasound, then you can take the help of the sonohistography, in which you put the saline, or you can do the hysteroscopy. Any case when there is a problem in the diagnosis, then sometimes the MRI is recommended, which is usually done in those women where the transvaginal ultrasound is not possible, like in adolescent or in virgins. Now about the management. After the classification and after knowing that in which group it comes, whether it is an adenomyosis, fibroid, and doing important investigation, then comes the management. The one-stop management is that take a proper history, examination, perform TVS and hysteroscopy, and classify it under the category of the FICO-AVUB system. For the myometrial assessment for the TVS, you have to categorize whether the myometrium is looking normal or it is abnormal, whether this is endometrial cavity is distorted or not, what is the thickness of the endometrium, is anything is present heterogeneous myometrium that is suggestive of adenomyosis, and sometimes this adenomyosis might be local, so it has to be differentiated from the leiomyoma. In this case, you have to take the help of the color Doppler or the MRI imaging also. So usually we more than 90% cases, the diagnosis of the fibroid or adenomyosis is very easy by the TVS. But sometimes when the diagnosis is in doubt, especially in cases of pedunculated subserous fibroid or it is associated with the TO mass, then you have to take the help of the MRI. So this is the, I told you that this is the algorithm showing how to diagnose it. Chronic AUB, yes, do the investigations, proper history, examination, physical examination, and then the added investigation. History, find out whether it is ovulatory dysfunction, any history of medication, any history of inherited disorders, and examination to rule out any uterine evaluation, and added investigation if you are suspecting coagulopathy, then for the von Willebrand disease or the platelet or the coagulation disorders, you have to assess accordingly. And then you have to assess the uterus. Do the TVS, find out any hyperplasia or neoplasia and any structural abnormality. If you find usually in the reproductive age more than 12 millimeter, or in the postmenopausal woman more than 4 millimeter endometrial thickness, then you have to perform the endometrial biopsy. Usually it is better to do by the hysteroscopy guided biopsy because you can take the precise biopsy. It can be very well examined by the cytopathologist. But if you are not having hysteroscopy or there is a problem, then you can do the diagnostic DNC and find out whether the patient is having malignancy or atypical hyperplasia. If it is present, then it will become under the classification of AUB-M. If it is normal, then it will come under the category of AUB-E or O. E means endometrial or O means ovulatory. Depending upon this, you have to manage the patient. If on the ultrasound, if you are suspecting any structural abnormality, find out whether it is a normal cavity or not. If it is a normal cavity, okay, manage on these lines normally. But if it is abnormal cavity, then you have to confirm it by the saline infusion sonography, whether it is a polyp or not, or do the hysteroscopy, find out whether it is a polyp, fibroid, or any growth, and accordingly you can take the biopsy, you can do the MRI, and can manage the case. So management depends upon the what type of the bleeding she is having, what is the age of the patient, then what is the severity of the bleeding, what is the underlying mechanism behind it, and most important thing is the desire for the further fertility, whether she wants more issues or not. So generally we are giving either the medical treatment or the surgical treatment, then the less minimally invasive surgery can be done. First, the most important thing, if the patient is anemic, we have to build up her hemoglobin. And then a hormonal treatment in the form of various preparations, where the progesterone can be given oral, usually oral, medroxyprogesterone acetate or the norethistron acetate, depending upon the how much the patient is having a bleeding. Estrogen, if there is acute bleeding, can be given in the injectable form. This is the most common prescribed medicine, that is a COC or the combined oral contraceptive pills. Danazol usually not given nowadays. GnRH agonist, if you want acute control and the patient can afford, then the GRH antagonist can be given. And the Mirena, that is a levonorgestrel, is the usually ICD is the most common choice of method of treatment on all the women who are having a bleeding. It can be very easily controlled and you can avoid the surgery also. Then the non-hormonal preparations are prostaglandin synthetase inhibitors, antifibrinolytics, and the ethamicillate ID. So you treat the patient by the hormonal and the non-hormonal treatment, and you cannot say that the which patient has to be treated by the which method. The patient, they have having a different response, and if the patient they don't respond, then you do the surgical treatment by the endometrial ablation, by the uterine artery embolization, and by the radical treatment, that is a hysterectomy. Hysterectomy means
मैम यूट्रस कट करके निकाल देता है.
हाँ, तो उससे भी, लेकिन डिपेंड करता है किस एज में है. तो ट्रेनेक्सामिक एसिड इज अ वेरी कॉमनली ड्रग It is an antifibrinolytic agent. It is a competitive inhibitor of the plasminogen activator. It is the most common prescribed drug is given because it is free of side effect. Decreases the menstrual blood loss by about 50%. It is very much cost effective in comparison to the levonorgestrel intrauterine device and free from side effect as compared to the non-steroidal anti-inflammatory drug. The contraindication of tranexamic acid is only one, that when there is already having a tendency of coagulation like Apla syndrome, anything, history of thromboembolism. The doses are the 1 gram, that is a 2 tablets has been given, BD, TDS or QID, and has to be given till the patient is having a control of the bleeding 4 days. The COX inhibitors is given to reduce the blood loss by 50%. And you know there is a mechanism of action that inhibits the prostacyclin, which is responsible for the increased blood flow and which prevents the platelet coagulation. The drug of choice is the mefenamic acid or the naproxen in the doses of 500 milligram and repeat it after 4 hours or 5 hours. Doses are 250 or 500 milligram TDS, but you have to be very cautious in those women who are having a peptic ulcer, nausea, vomiting, headache, like this, because they may cause the aggravation of the peptic ulcer. Then comes the progesterones, that is known as a, what is the difference between the progesterone and progestins? बता सकते हो बच्चे? Synthetic progesterones, they are known as the progestins. So progestins are given to inhibit the growth, to inhibit the synthesis of the estrogen receptors. It stimulates the activity of the enzyme 17-beta hydroxysteroid dehydrogenase. And when it is given in the doses and it is taken properly, then it is a very good method for the control of the bleeding. It might be given as a cyclic progesterone, as a continuous progesterone. Then the Mirena. The Mirena is a very good method for the control of the bleeding. IUD means intrauterine device. Once you insert it, it is effective for the 5 years. Only disadvantage is that it is costly. It comes under about 2,500, 3,000. But added advantage is that it is a very good method for the control of the bleeding. About 80 to 90% patient, they respond to the acute bleeding also. And the mode of action is that it prevents the endometrial proliferation, acting at the endometrial level, acting at the cervical level, inhibiting the ovulation also. And it is affecting in both the cases, whether it is hormonal and non-hormonal method. And in more than 90% cases, it can avoid the hysterectomy. So it is a very good method. So by the FIGO, it is recommended as the first line management, first line therapy, if there is no evidence of any structural or histological abnormality. Even in cases of endometrial atypical hyperplasia, if patient is not desiring, doesn't want hysterectomy, and she wants fertility, you can prescribe the Mirena. The side effects that in some cases it might have the bleeding disorder, slight irregular bleeding in between the cycle, and 20% of the women, they develop the amenorrhea within 1 year. So second, after the progesterone and after the Mirena comes the COC, that is the combined oral contraceptive. Nowadays we are giving in the low doses. These are the estrogen and progesterone. The combination is given 5 to 25 days. Action is that it prevents the suppresses the hypothalamus pituitary ovarian axis. It is affecting in more than 50% of the patient, and it can be given in ovulatory and ovulatory type of the bleeding. Side effects: headache, weight gain, breast tenderness, jaundice, hypertension, and the thrombotic state. The fourth drug is the GnRH analog. Usually it is a costly drug, so it is given only in those cases where the patient is not responding to the prescribed drug I have already mentioned. And second disadvantage is that it causes the suppression of the GnRH, So it causes the decrease or the absence of the estrogen or progesterone. So these patients, they are having amenorrhea, and they are having the symptoms and the signs of the hypoestrogenic in the form of amenorrhea and the osteoporosis and hot flashes. So always when you give the GnRH more than 3 months, you have to give the add back therapy, or you have to give the estrogen progesterone in combination. If the patient is having a very acute bleeding, then you can give the estrogen or 25 milligram IV, which is not available in our country. Monophasic estrogen, that is a OCP 3 times for 7 days. Then change it to daily for 21 days when there is a stoppage of the bleeding. Medroxyprogesterone 20 milligram TDS for 7 days. Tranexamic acid has been given 10 milligram per kg IV, maximum dose 600 milligram per dose, or 1.5 milligram orally every 8 hours for 5 days. So this is to control the bleeding acutely. In the chronic, I have already mentioned that depending upon the type of the bleeding, depending upon the symptoms, whether she is anxious to have the more pregnancy, whether she is taking the drug properly or not, whether she is responding to the treatment or not, if there is any side effects or contraindication to the drugs, then what are the associated comorbidities like diabetes or hypertension. So depending upon this, you have to manage whether you should give the surgical treatment or the medical treatment. But before giving all the surgical management, a careful assessment of the risk benefit has to be assessed depending upon the patient condition. So individualized, or you can say a tailored approach is a must. In chronic cases, all the drugs can be given in the doses I have mentioned. That is a ibuprofen, that is a non-steroidal anti-inflammatory drug, medroxyprogesterone, depot medroxyprogesterone, levonorgestrel, tranexamic acid, all can be given very easily. Then the surgical management is the transcervical endometrial dissection, which can be done by the thermal balloon, Nevershore, microwave, laser, rollerball. Means you apply the heat on the endometrium and you destroy the endometrium. That is a transcervical endometrial resection also. And then by the uterine artery embolization, you decrease the blood supply to the uterus, or the hysterectomy, that is a removal of the uterus. Commonly nowadays, we are not doing all the thermal balloon might be done. We are not doing any other method. The uterine embolization and the hysterectomy, if it is not responding, these are the common procedures. So to classify or to summarize, it can be said that the AUBP, A, L, M. P means polypectomy, A means adenomyosis, leiomyoma, depending upon the age, you can perform the hysterectomy if it is more than 40, less than 40, you do the medical treatment, GnRH or the levonorgestrel. If it is not responding, you can proceed the surgery. In M, that is malignancy, atypical hyperplasia, you can have the Mirena, not responding, hysterectomy. In no atypia, then levonorgestrel IUS is the first choice. So like this COEIN, you can do the same treatment. Coagulation disorder, you can have the desmopressin or whatever the treatment. Ovulatory disorders, you can give the levonorgestrel first choice. Then the surgical treatment if it is not responding, E, I, and N. So accordingly, you have to manage. So thank you very much for active listening and giving so much attention. Now I have finished it. Do you want to ask any questions or should I ask some questions? Love Kumar?
Yes, ma'am.
हाँ तो बताओ, what is the cause of bleeding in adolescent?
Ma'am, there is structural causes and non-structural causes. In structural causes, there is
Adolescent में very good. Structural and non-structural, very good.
ma'am, palm classification and there is coin classification. It include, ma'am, adenomyosis, leiomyoma.
नहीं, सबसे एडोलेसेंट एज ग्रुप में अगर ब्लीडिंग
malignancy.
ज्यादा होती है तो कॉमन कॉज क्या होता है?
मैम एस्ट्रोजन विड्रॉल होता है
कोगुलेशन डिसऑर्डर्स है ना, ब्लीडिंग डिसऑर्डर्स, वॉल्व रिब्रांड डिसीज, ये सब आपको एक्सक्लूड करने हैं, है ना।
यस
अंकिता,
यस मैम।
हाँ बताओ, पॉलिप कैसे डायग्नोज करते हैं?
फ्लूइड इन्फ्यूजन,
सलाइन इन्फ्यूजन सोनोग्राफी।
यस मैम, सलाइन इन्फ्यूजन।
और क्या मेथड है? ट्रांसवेजाइनल सोनोग्राफी आल्सो।
यस मैम, ट्रांसवेजाइनल सोनोग्राफी।
अदिति,
Yes, ma'am.
कितना है फिगो का फाइब्रॉइड के लिए क्लासिफिकेशन, अंडर विच कैटेगरी?
Uh,
कितना फाइब्रॉइड का टाइप बताया था बेटा?
subserosal, mucosal, हम 0 से 7,
हाँ,
0 से
गुड,
8 तक था।
वेरी गुड। अंशुल, अंशुल,
Yes, ma'am.
can you summarize the lecture in three lines?
Ma'am, in a lady presenting with abnormal uterine bleeding, we should be ruling out the coagulopathies. And in an aged female, we should be checking out for endometrial functions. Ma'am, the TVS to rule out endometrial disorders.
ठीक, और बताओ कैसे क्लासिफाई करोगे?
मैम क्लासिफिकेशन तो पाम कॉइन के हिसाब से करेंगे। मैम
ठीक, और उसमें भी इन्होंने फिर बाद में क्या ऐड कर दिया?
मैम आई डोंट रिमेम्बर।
acute chronic, then intermenstrual heavy bleeding. ओके,
यस मैम।
ठीक है बच्चा। और कुछ सवाल पूछना है? सवाल पूछना है? शुड आई स्टॉप द लेक्चर? शुड आई लीव? टेक केयर।
थैंक यू मैम।